Welcome, everyone. It is my pleasure to introduce the session, Updates in Pediatric Liver Transplant, 3 things to know about liver transplant. Please feel free to ask your questions during the presentation in the Q&A area, and we will answer them during the presentation, or the presenter will answer them later and we will post them to our website. I'm Stephanie Mullet, and my son Bryce had a liver transplant whenever he was 10 months old in 2018, and my husband was his live liver donor. I'm on the board of directors for Transplant Family. I am honored to welcome Dr. George Mazareigos, who specializes in pediatric transplant surgery at UPMC-Children's Hospital of Pittsburgh. Thank you.
Good afternoon. Thank you for that introduction, and it is a privilege to be presenting at the Transplant Families Conference this year. I've been asked to talk about common questions that families who are facing potential transplant for liver disease may encounter. So I've decided to title my presentation, What is the best liver transplant graft type for my child? And other things I've always wanted to ask. I'm George Mazareigos. I'm the Chief of Pediatric Transplant at the Children's Hospital of Pittsburgh. And you can follow me on @CHP Transplant on X, or email me anytime for additional questions that you may have in follow-up of this presentation. When you're at the point of your child needing a liver transplant, I understand that there may be so many questions that are entering your mind that are continually bombarding you, and with opportunities to investigate further, with questions that you've heard, with advice from others. We could spend a whole week talking about some of the things that we've learned over time, but I'm going to try to distill this into 25 minutes of a discussion that can hopefully point you in the right direction. I've decided to divide the presentation into just four parts. What are the next steps in deciding about a transplant center? What type of transplant should I get? And by that, I mean, is it going to be a whole graft? Tell me what a split graft is. Tell me what a living donor graft is. And then some common, just nuts and bolts practical questions. What if I have to travel outside of my city or my state for a transplant? And what's this option about second listing? What does that mean? And is it something I should consider? Before we talk about those things, I just want to do a very quick refresher about what diseases lead to liver transplant in children. There are many resources for you that are available, and I understand that every child is different, and your child may have a more rare condition. But typically, children who need a liver transplant fit into some of the categories that I've shown here. The most common indication is the cholestatic diseases, of which biliary atresia is a common example. The next biggest category is the metabolic conditions, and I'll have a second slide about the conditions that lead to a transplant out of the metabolic realm. Sometimes children present out of the blue where they've been previously healthy and then have acute liver failure and acute presentation of liver illness that requires transplantation. Sometimes the cirrhosis is from other causes. Sometimes tumors lead to transplant. Urea cycle is a specific large category of metabolic disease. And some children need retransplantation. This is about 10% of the indications for transplant. But biliary atresia and metabolic disease, they're the most common categories. If you have metabolic conditions, you may fit into one of these disease classifications where genetic perturbations lead to liver disease or lead to systemic disease. And many times liver transplant can be a definitive or significant cure for your child. One of the things that has been fascinating and dramatic in the last 5 to 10 years is that the number of diseases that we're discovering where liver transplant can be a cure is actually increasing. For the most part, liver disease and adult transplantation is fairly stable. They're not new diseases that are being transplanted, with some exceptions that haven't been transplanted for a long time. But for children, we're transplanting diseases in 2024 that we weren't transplanting in 2000. And so the ability to understand genetic conditions has allowed us to potentially understand better where liver transplant can help. So for example, in our overall compilation of over 400 children that we've transplanted for metabolic conditions at the Children's Hospital of Pittsburgh, you can see that alpha-1 antitrypsin is significant top that category. Maple syrup urine disease is the next largest category. We have a significant number of the genetic conditions called familial cholestasis, and then other diseases like Wilson's, tyrosinemia, cystic fibrosis, glycogen storage disease, Crigler-Najjar syndrome, the urea cycle, and others. Your genetic doctor and your liver physician are the best source of information for understanding the right time, the right process to begin seeking out information about when liver transplant may be indicated for these different conditions. But assuming that we've gotten to the point where you're really looking at where should my child undergo this transplant and what are the questions that I should ask to my transplant center, we'd like to give you some practical steps that may help you in this process. There are potentially many steps that I could list here, but I just wanted to give you a few practical resources and just some overall advice from a perspective of both a transplant team leader and member, but also a dad and someone who has walked through this journey with many families over the past years. My first advice is to understand that you are not alone. When you have a child with liver disease or metabolic condition that may need a liver transplant, sometimes these are relatively rare conditions, and you may know one or two other families that have had this, or you may not know any families who have ever directly communicated with you about this journey that they've been on and that now you're joining. But what I want to encourage you is that you are not alone. There are thousands of children who have successfully undergone the transplant pathway and are now living with functioning liver transplants and really beginning to reach the potential of being the child that they were meant to be. I love to share this encouragement because I do believe it is truly a remarkable accomplishment that in the United States, there's over 35,000 children who are living well today because of successful kidney, liver, heart, lung, and intestine transplants or multi-organ transplants. This is data from the SRTR. You're going to hear a little bit more about that in a minute. The SRTR is charged with recording the data from the United States centers and trying to make it as easily digestible as possible for both physicians and medical teams, as well as family members, to try to understand the data that's been accumulated over the past decades for children undergoing transplant. And you can see here that kidney transplant patients number about 12,000. Similarly, we have a growing number of liver recipients, about 10 to 11,000, and then heart, lung, and intestine recipients who are all doing well after their transplants. And this data continues to grow every year. The way that I try to communicate this is that you are joining a group of patients and families who really have similar concerns and questions about the post-transplant journey and what normal life after transplant will look like. And our job is to connect you with those resources. What are some of those resources? Of course, Transplant Families is a fabulous resource, and I know that you have opportunities to really work and dig into some of the resources that they have. I always refer families to their physician and surgeon team locally, their trusted medical advisors who know the specifics of your child's condition. That is a key number one resource for you. I'd like to point out a couple of other web resources. We work very closely with transplant families in a learning health collaborative called the Starzl Network. This is a learning health system geared around pediatric liver transplantation that began a little bit more than 5 years ago. when 16 centers banded together to try to work collaboratively rather than competitively to advocate for the key patient-driven priorities of our transplant needs and teams. And so with working with transplant centers, patient families, and industry leaders identified some of the key problems. And patient and family group leaders have worked together to develop resources that would be of most help for patient and families. The second is the SRTR. Before I go into the SRTR, let me just show you a little bit about what is available for you on the StarzonNetwork.org. StarzonNetwork.org is a resource that includes educational materials and videos that have been developed in collaboration with multiple transplant centers. They're meant to be applicable to patients entering the transplant journey and then walking through the transplant process at different time periods. And they've been developed with you in mind. They've been developed to try to apply across the board for the patient who is undergoing transplant at any one of the sites or at other sites in the US. And so you'll find them to be, I believe, really focused on identifying and addressing the common questions that you have. One of the tabs in the StarzonNetwork.org website is called Resources. And under that, and these include multiple PDFs and other documents that have been developed, some in collaboration with transplant families, but all of them in collaboration with patient and family representatives who have walked in your path and are now on the other side of the transplant process, helping their child to reach their full potential and helping others as well. One of the specific tabs under the resources page is a very, very lengthy document, which is really, I think, well suited for your perusal. It's called Family Resources for Liver Disease. And I just took a screenshot of that today so I could share with you. There are multiple family-led resources that have been vetted by many of the care teams and can provide additional resources, some of them specific to your patient's or your child's liver disease. Secondly, I would encourage you to look at the SRTR.org. That stands for the Scientific Registry of Transplant Recipients. And the SRTR.org website is designed to really try to make it easy for you to find out the basic results of transplant outcomes for centers in your area or across the region. When you look up a transplant center in your region by state or by name, you can find out how many transplants from deceased donors that center did in children, how many transplants from living donors they did, what their metrics are for survival on the wait list for getting a deceased donor transplant faster, and for their one-year liver survival. You can find out what happened to those patients who were on their wait list, how many were removed and why. You can also ask sub-questions or to a certain degree and say, did many people die on their wait list? And did many patients get transplanted at other centers from that site? So I encourage you to look at that. It is publicly available, and the data there is validated. It is one of the ways that you can get information about transplant centers, but it's not the only way. Unfortunately, the SRTR data is limited to generally short-term outcomes. So it does not tell you things like what will happen 5 or 10 years from transplant at that center or for my child. It does not tell you, in general, disease-specific questions. We'll talk a little bit at the closing about some of the long-term projection of transplant for children undergoing transplant now in the United States. But data limitations at the SRTR limit the ability of family to say, I understand that transplant outcomes are such and such, but I'd really like to know what the outcomes are for biliary atresia only, or the outcomes for hepatoblastoma are at these sites. And it is to answer these questions that you really need to ask specific questions of your transplant center. What is the specific experience that you have with transplantation for biliary atresia? What are your 10, 15, and 20-year outcomes? How many patients of your center need to be retransplanted? What type of organs do you use to transplant your patients? What is the waitlist mortality at your center? These are questions that can help you in trying to get more detail on the questions that really matter to you. My recommendation would be to make a list of these questions. You can use this talk as a resource or other talks. And when you meet your transplant professionals, you can address some of the specific questions that they have and be able to answer those and to begin to go a little bit deeper than the data does allow you based on these public websites. Let's talk for a little bit about the type of transplant my child should get. Now, in the United States, we have various transplant options, but we don't always apply them in the same way. And so these are pieces of information that will be valuable to you in visiting with your physician and surgeon team. In the United States, we are able to get a liver transplant from a deceased donor, both a child or an adult potentially, and that deceased donor who has been declared brain dead or death after cardiac death has given permission for his organs, his or her organs, to be a life-saving gift of transplant to a child or to an adult. We can use the liver in its entirety. The whole liver is on the picture is a schematic from a publication that depicts some of the ways that the liver can be divided. It can be used as a whole liver. It can be used as a partial liver. So you can see on the right hand, it's a picture from our Pittsburgh artist who depicts a typical partial graft or a left lateral segment graft. This could be either from a living donor, a portion of a liver from a living donor, or a split from a deceased donor. What is the typical experience in the United States about these grafts? This is data from a few different sites. The Society of Pediatric Liver Transplant on the left, reporting on over almost 3,000 transplants, multi-center registry collaborative looking at outcomes for liver transplant, and the UNOS or OPTN data, the United States data of the Organ Procurement and Transplant Network. You can see they're fairly similar. In the United States, about 50% of the pediatric transplants are whole livers, and about 15% are living donor transplants, and about 33% are deceased donor split liver grafts. What is better? Which graft type is the best for my child? How do I decide? And what centers do which procedures? I'll show you a little bit of data, but I think the first important piece of information and goal is that every child should get transplanted when they need it in the United States. The first step of this journey of transplantation is getting transplanted safely and well. And the waitlist goals have to be 0. That is our goal that we're striving for in the Starzl network and in the country. And we want to shed light on how we can best get there. In order to do that, myself and colleagues from the Starzl network published last year an analysis of the OPTN data, the Organ Procurement and Transplant Network data over 15 years for children who were listed for liver transplant in the United States in centers that had done at least 10 pediatric transplants over that time period. And we looked at the waitlist mortality. We looked at how often they used technical variant grafts, these grafts defined as either splits or living donors, and what the outcomes were over time. In this analysis, we had over 9,000, almost 10,000 children that we looked at, and 64 centers performed almost 8,000 transplants. But in this time analysis, over 650 children died on the waitlist. And the proportions, sadly, of waitlist mortality varied from very low to 31%. This is a schematic of 64 different transplant centers arranged in this case by the proportion of waitlist mortality. And you can see that there's a wide range of waitlist mortality from very high to centers that had a low proportion of waitlist mortality. The other depiction here is of the variation of how many centers used only whole livers, how many centers used living donor grafts, how many centers used deceased donor grafts and of splits, and et cetera. And you can see that there's wide variation in the practice. We wanted to look a little bit more at trying to tease out, did it matter if you used more split grafts or living donor grafts? Was that advantageous? So looking at the types of graft types in this analysis, as I showed you before, like we said previously, whole grafts were a little bit more than 50% of the transplanted population. And of the 3,155 technical variant grafts, almost 1,000 were living donors and 2,100 were split graft types, a deceased donor that was split into a left lateral segment and a portion for an adult transplant. We believed that the greater the proportion of technical variant grafts that were utilized, the better the outcomes and the lower the waitlist mortality would be. And indeed, that was true. This graph, which is part of the publication that we submitted to liver transplant, showed that there's a wide variation in practice. So each dot represents a different transplant center in the United States. And the more that these centers utilized living donors or split donor grafts, the lower the waitlist mortality was, and the better the long-term outcome. Either living donor splits, the living donor, or deceased donor splits achieve this outcome. The impact of living donor liver transplant was particularly strong, and these recipients had significantly increased survival from transplant compared to the other graft types, although deceased donor technical variant grafts had similar outcomes to whole liver grafts. They weren't statistically different. This impact of living donation has been supported by other meta-analysis. That means a compilation of various reports and published literature that demonstrates a improved long-term survival, less graft loss, potentially because of the lower risk of rejection in pediatric living donor liver transplant recipients. Recently, we had the privilege to perform Children's Hospital 200th living donor transplant in a young lady from Alabama. And living donation is an important tool to ask your center as you consider liver transplant. But split liver transplantation is also important. This is analysis from the OPTN group of patients who were particularly worried about those most at risk, the small babies. And in this analysis of SRTR data, a decision to accept a split liver was associated with a reduction in waitlist mortality, especially for children who are under 7 kilograms. So an important part of the toolbox to care for children today at the right center. Let me shift a little bit to a couple really important questions that we'll touch on. What happens if I decide to travel for my transplant? And what's this option about second listing? Multiple listing or listing at another center is something that is an option for all transplant patients in the United States. It is something to bring up with your physician, and there's information and details on the hrsa.gov website about multiple listing that I recommend you take a look at. If you're comfortable and you've asked all the questions and you feel like your center is the right center, then this may not be needed. But as your child continues to walk through this process, or if you feel that you'd like to explore this is something that you should ask your care team about. In my experience, sometimes starting a conversation is the hardest thing because we perceive that other centers our initial transplant center may be offended or that this is an unusual request. But I find that phrasing the questions in certain ways helps families initiate that. For example, you could say, I understand second listing is an option for my child. Can you tell me about that, please? Another way to add on this would be to, if I decide to do that, where would you recommend I go and who can help me to start this process? Similarly, at the other site, when you begin to have that discussion with the other transplant center, you want to ask some specific questions because you will be traveling out of state. You will be traveling potentially a long distance to come to transplant. So you want to ask them things like, tell me a little bit about your expectations to be treated locally. How long do I need to stay in town? Tell me about your experience with out-of-state transplants. Tell me if I can speak to someone who can help me understand any insurance coverage issues I may have after transplant. As we wrap up this discussion, I want to encourage all of the listeners and participants that we really have an opportunity to really look for the long term. And by long term, we mean your near normal lifetime of your child, a normal lifetime of your child. And team members, our community, the Starzl Network, transplant families, collaborators, we're working on optimizing all these areas of opportunity, getting you transplanted, helping you stay well until that life-saving transplant is done, optimizing the first year after transplant and the operative period, the first year, and then sustainable health over the next decades. I wanted to close and just show you this data, which I think is really remarkable and encouraging, and that is that projected models demonstrate that 30-year patient and graft survival for liver transplant children that are transplanted in a current era are at least 80% at this current time period. And again, as I mentioned, there may be conditions, metabolic conditions, or subsets of liver disease that have an even better outcome projection than this. Projections are needed because we haven't transplanted patients routinely until the most recent 20 years. But we do have evidence on very early survivors that help us develop these projections. I'll close with this story. This is Todd, who was the first transplant patient recipient at the University of Pittsburgh Children's Hospital in 1981. This is Todd 30 years later, and now continue to care for him 42 years later. He's also off immunosuppression with satisfactory liver function. So that there are people who have gone before your child and are part of that community that I've talked to you about. I want to thank you on behalf of our children's transplant surgeons. We try diligently to honor the legacy of Dr. Starzl, and this is a memoriam to him at the University of Pittsburgh campus that sometimes I visit and ask him what he would do. I hope that this has been a good discussion, and I look forward to some live Q&A if there's time. Thank you.